Well, thank you for joining us this evening for our discussion on a journey of emotional well-being and diabetes management. We're also aware of the importance of working with our meal plans, engaging in exercise, taking our medications, and monitoring our blood glucose in our diabetes management. But we can never underestimate the impact of our emotions on our diabetes. So today we are very pleased to have a panel here for discussion. I'd like to introduce Dr. Barry Simon, who's a psychiatrist and a psychoanalyst, and Dr. Alana Wiseman, who is a practicing endocrinologist. And my name is Gail McNeil. I'm a certified diabetes educator. Now, there's so much talk, and we've had so many great questions from the audience that have come to us through our annual survey from Diabetes Care Community. And hopefully many of you have contributed to those. And although we'd love to answer all those questions, we have a certain agenda that we've set out today. So we're going to be talking about discovering the mental health challenges of living with diabetes. We're going to be talking about creating an action plan and engaging your healthcare team in your action plan. And following our conversation today, we have approximately about 10 minutes for questions. So as we talk through this program today, please submit some questions and we'll work with as many of those as we can at the end, okay? So to start our journey through the mental health and looking at how that affects diabetes, I've had a question for Barry here. When you think of challenging emotional moments for people, moments when they're taking care of their diabetes and they're frustrated or angry or distressed, how do you begin to help them understand the emotional impact of diabetes?
Well, thanks, Gail. The key is to first realize that diabetes is a stressful illness. And it's stressful not only because of all the demands you have, it makes you deal with it many times a day. So you have to check your bloods. You have to decide how you're eating and how much carbs there are in food. So it's a chronic stressor. When people are chronically stressed, they inevitably have more negative thoughts. And it's those thoughts like, I can't do this anymore. It's overwhelming. This is ruining my life. Or I can't believe I got a blood sugar of 11. I thought it'd be 7. All of those kind of thoughts lead you to feel emotions. And those emotions lead to actions. So when I want people to begin to start to think about diabetes is actually as much a mental health exercise as a physical health exercise. And it's that negative self-talk that they need to manage. So I always say to people, it's not the situations I want them to manage, it's the thoughts I want them to begin to notice.
Oh, that's beautiful. It's not the situation, but rather your thoughts about the situation. So you've got us thinking already, Barry. Thank you for that one, okay? Now, Alana, you are a practicing endocrinologist. Now, when you have patients in front of you in your office, do you recognize stress? And if so, how do you start to work with the stress that you see in your patients?
Thanks, Gail. Yes, so I think as Barry was alluding to, we can see evidence of stress when it's become sort of a hindrance to diabetes care, and that can become evident during appointments with the endocrinologist. And that can manifest in a variety of ways. There are some patients who will describe emotional eating or eating in relation to stress, and that can have a negative impact on their blood sugars, negative impact on their weight. And that can have a whole host of negative consequences on their health. We can also see patients who are feeling like they just want to give up, that things are not going well. And because they can't manage things optimally, there's just no point and why bother trying anymore. And so we can see some people who may actually stop taking their medications because of feeling this way. We might see people who should be monitoring their blood sugars, but stop checking them because of feeling this way, and sort of really letting their diabetes management go off the rails because they're just feeling so overwhelmed and that they can't possibly manage. We may even see people wanting to avoid appointments because They worry that coming to see their doctor and hearing the results of their blood tests or hearing that they're not doing well, they're scared to hear this. And so they might actually avoid attending appointments, or avoid providing the information at appointments like their blood sugars, if they're worried that those numbers are not going to please their doctor. And so one of the points I wanted to make today is that as doctors of people with diabetes, we ask to look at blood sugars, we do these blood tests, we check your blood pressure. And this is all data that we're collecting, and it's for feedback. It should not be used as a sense of judgment. So when you're seeing your doctor, you should not, feel that you're a failure if the numbers are not where they should be, or where you think your doctor thinks they should be. There's still value to discussing these numbers, even when they're not perfect. And so we can summarize this by thinking about the numbers and the data as being for feedback, not for judgment, and not to ascribe a sense of failure.
It is great to hear your viewpoint, Alana, from the endocrinologist, because we often don't hear that side of it. And you're absolutely right. I think a lot of us don't like to go to physicians because we're afraid we're going to be judged. So I think it's very important for us to hear it's the feedback, not the failure you're looking at. It's the data, and you're there to help us in this situation. Exactly. Thank you. We really appreciate that. Now, before we go any further, we need to clear the air about one particular aspect. Difference between diabetes distress and depression, and they often sort of get mixed up. Barry, can you help us explain what is the difference between depression and diabetes distress?
Sure. So let's start with diabetes distress. Diabetes distress is not a psychiatric illness. It's not an illness at all. It's when stress reaches the point that people feel unmotivated, overwhelmed, maybe even have a sense of burnout and just want a vacation from their diabetes. But the rest of their life is going reasonably well. So it's around the emotions you have around diabetes. And when those emotions go from sad or frustrated to angry, ashamed, guilty, and even lead you to want to back away from your care, that's diabetes distress. Depression, on the other hand, is a psychiatric condition. And as a psychiatrist, I see it every day. And that's more a general loss of interest in one's life. And at the same time, there's a black depressive feeling about one's entire life. So it's much more comprehensive, and it comes with feelings of not being able to concentrate, difficulties with energy, able to focus and enjoy things anymore in life. And if someone's really depressed, they may even have thoughts of harming themselves. So it's a completely different condition. Tonight, we're trying to focus on diabetes distress, and even before that, just the distress of living with diabetes. And that's our topic for tonight. We can talk later about if you're worried you have depression, what you might want to do, but I can tell you it starts with reaching out to your family doc.
Okay, thank you so much, Barry. So let's be clear, diabetes distress is not depression, and diabetes distress is related to the activities that we're involved in and our emotional involvement with the activities for our daily care for diabetes. Okay, thank you for that. Okay, on to our program then. One of the biggest questions and the most popular questions is the idea about feeling overwhelmed. We often get patients express that are just overwhelmed with all the constant demands, as you were talking about, Barry, about keeping track, and Alana, you were talking about this as well, about the blood sugars and keeping track of meals and food and medications. So here's a question. Barry, I'll start with you with this one. When a patient with diabetes says to you, I am overwhelmed, what is your response?
Okay, so I begin by saying to them, saying that you're overwhelmed, I know that's how you're feeling, but let's start to drill down to the actual situations that lead to feeling overwhelmed. Now, people know about cognitive behavioral therapy. It's the most common therapy that's done for depression, anxiety, but I use the same model when it comes to diabetes distress. I say to people, it's not actually the situation. Let's take the example of testing your blood sugar. It's not the actual situation, it's your thoughts and the images you have about the situation that lead to your emotional reaction. So for example, let's say the situation's testing your blood sugar and you have the thought, I never thought it was going to be that high. That's ridiculous. I don't know what's going on. Your emotional reaction may be to feel, as I sounded, quite anxious, frustrated, possibly annoyed. What follows then is some sort of behavior. And the behaviors that follow are often avoidance. And you need to catch yourself having this conversation, because a blood sugar of 11, Alana would tell me, is easily dealt with. There's ways to cope with it. Uh, Diabetes educators are teaching people all the time, but it's that thought, I wasn't expecting it. I've ruined everything. This isn't working out, that leads to the behavior of wanting to give up. So it goes back to that idea that you want to catch that thought and ask yourself a really simple question. Is that a helpful thought? So once I have someone actually catch the thought, I ask them, is that helpful? And what would be a more helpful thought? So this slide really helps you understand that it's not the situation, but it's our thoughts that matter. So one of the common reasons people come to see me actually at Mount Sinai is when they're told to start insulin and they're overwhelmed by the idea of it. So Alana might say to somebody, your care is such that it's now time to start insulin. Pretty straightforward recommendation. What people are hearing in their head are a whole variety of thoughts. So let's look at this first one. Alana says, hey, I recommend you start insulin. The person thinks, I must be doing really bad. And they begin to feel anxious, they worry, and they don't even hear another word that she says, which is, with insulin, your care is going to really improve, your complication risk is going to come down, and it's really not people will teach you how to use it. They're long not listening, and it's because of this thought, I must be doing really bad or really badly, that they begin to get all anxious and retreat inside. A completely different person might say to themselves, I don't want to give myself needles. And even though Alana said it in the nicest way, it's that thought that matters, and they cancel their follow-up. So we need to catch these thoughts that before we get into trouble. The final one is the one, if we just go back to that last slide, the last one, I think we should have a positive one. I recommend you start insulin. My aunt started insulin. Her blood sugars are great. The person at that moment, because of that thought, says, great, what do I need to do to start? So it's our thoughts that matter. And you want to ask yourself, once you catch your thoughts, because we can't control our thoughts. I want to say that again. We cannot control our thoughts. They pop through our head, but we can always respond to them differently by asking ourselves what might be a more helpful thought. And that's the journey that I take people through in all the different situations that are around diabetes distress, is to begin to look at their thoughts. Last point would be that, that people find diabetes overwhelming, and that's totally normal. And I really want to stress that. It's normal to be stressed by diabetes. What you want to do is develop the coping skills because you have this stress, because you feel a sense of threat. And we'll talk more about that in a minute or two.
Wow. So catch your thoughts. I think that's great. That gives us some insight. And as you say, it's not the situation, Barry, it's the thoughts that we have about the situation. Research has shown us that this diabetes distress can be categorized into several different sort of areas, and each area can have a potential problematic for the person with diabetes. Now, there is a self-assessment tool that's on the Diabetes Care Community website, and it's called the PAID scale. If you take this PAID scale, it will help you personalize your actual stress areas, and you can start to identify what areas are actually causing you more stress. So I encourage you to take a look at that on the Diabetes Care Community website, and to actually take the scale and see what the results will come to you. Now, there's two particular areas that we've had a lot of questions from the audience, and those are particularly the regimen distress and family support. When you're looking at these areas and you're actually found what's causing you the most distress, there's a question you need to ask yourself. is the anxiety that you have from those particular areas, is it due to a knowledge deficit, which we can work with, or is it due to this negative self-talk that Barry's been talking about? Now, a lot of people, as Barry have said, they feel overwhelmed with all this regimen. Now that you realize that that's where you're at, Alana, every day you're working with patients, how do you start to work with them so that they can come around to look at some goal setting, understand where they are, where they want to be, and help set goals, especially in somebody, we see this a lot, people that say their A1C is around 8%, and everybody knows it should be in the 7 or lower, right? So they have anxiety when they come to you and they know it's higher than it should be. But how do you help them set goals that will help to ease their distress?
Yeah, so I do see this quite often in my practice as an endocrinologist. And I think, it's important for me to identify that in patients who are struggling or who are feeling that way. And I think usually, we do a good job of identifying patients who are potentially struggling. And I think it's really important to make a plan. So you can help patients who are struggling with making a mental health action plan. And when it's specifically distress about the regimen, so often that's, dealing with the how to manage diabetes, whether that's in insulin injections, whether that's medications, monitoring the blood sugars. And so I a few helpful strategies that I have found is, first of all, discussing with the patient, how do they think things are going and what is their goal, and making sure that we're meeting, at some common ground, because what your goal is may be different than, what the recommendation is for an A1C less than 7%. If somebody's A1C currently is really high, let's say 10, 11%, it may not be a reasonable goal by the next appointment. And it probably is not a reasonable goal by the next appointment to have an A1C of less than 7%. So it's choosing something that is reasonable, that's achievable, that's feasible, and that both you and your doctor agree on is a step forward. So I think first finding that common ground can be really helpful. Another strategy I find that can be really helpful is taking small steps, so making small incremental goals. And so it may not be reasonable to say my goal is to get an A1C of 7%. If this is, if you're feeling overwhelmed to the point, like we talked earlier about, feeling like you want to give up, or you've stopped even checking your blood sugars, even though you should be checking them because you're feeling a lot of diabetes distress and just feeling overwhelmed, then, setting a goal A1C, may not be the next step that you need to take. And so it's very reasonable to have smaller incremental steps toward that goal. And as an example, often a goal I will set with people who are experiencing that level of distress is actually, can you start monitoring your blood sugar? That might be the first step. We're not even talking about what the numbers should be or what the goal for the numbers are, but let's just start monitoring. And maybe it's monitoring once a day. Let's pick a time of day that's going to be the easiest for you, the most consistent, that you won't forget. And if that's all we, move forward with before the next appointment, we've accomplished that goal, and then we can set the next one. So I think the two key things here are really individualizing your goals based on your specific circumstances, and then making small incremental steps forward when things may be challenging and it's difficult to sort of meet all of the recommendations. Let's pick one thing at a time, or something that's going to be accomplishable. And so I think, yes, this can be summarized as collaborative goal setting between you and between the physician.
Right, thank you. And I heard you say earlier, Alana, that we don't have to be perfect, right? So set the realistic goals and small steps along the way. Very, very important for us to realize that. Another area that the audience has sent us questions in is talking about family support. And this is one of the comments patients stated, my family never asked me about my diabetes. At family get-togethers, they never asked me what is best for me. I feel all alone with this disease. And I have heard that repeatedly in the office where the patients do not feel supported. We've talked about the support from our healthcare team. We'll have a little bit more to talk about that. But what do you do when you're living with your family and they seem to be ignoring it? Well, I looked into this and thinking about this. Is the family avoiding discussion of your diabetes out of fear? Because an international study looking at family members of patients with diabetes found that the family members' biggest concern was the fear of complications for their loved one. So as we discussed earlier, fear can lead to avoidance, which can be a real problem. So let's put to use the strategies that Barry and Alana have been chatting with us about. So 2 steps to recognize our problem here is there negative thinking, my family's not supportive? Is that really a helpful thought?
Mhm.
Maybe we should think something about what would be a more helpful thought. How about who is supportive? Is there anybody there that, search for somebody? And then the other thing is, when Atlanta was talking about realistically, what would support look like to you? So sort of know what you might be looking for. And here's the last question you can ask yourself is, how can I ask for more support? And one little key area that I've worked with a lot and I found really works is use the tool, the I conversation. And what does that mean? You say to a family member, you make me feel that my diabetes isn't important, or you are not supporting me. When you do that, the other person might feel attacked, they might feel threatened. So instead of saying something along that line, how about saying, I feel that you are not interested in my diabetes, or if you put the I into it, it seems that the other person is a lot less threatened in it. And it seems that you're taking some accountability and seeking out. So this open and honest communication, I feel, really helps to take the elephant out of the room, okay, sort of thing, and using the I part. Barry, what do you think about that?
That was a great answer, Gail. That's what I think. Uh, so that's one thought. The other thought was that, when you're under threat, back to the whole idea of situations and emotions and thoughts, we feel alone. Anytime we're under threat, we feel alone. And we want to remind ourselves of that there's a tendency to feel alone when you're under threat. And you want to be able to say to yourself, think the best of your family members, give them a chance. And I think Gail's comment that they're worried about complications leads them to be quiet too. Just having, an open eye conversation is a great way to introduce that. And I think that was really well said, what
Okay.
you had to say. Thank you, Gail.
But that also brings us into the conversation too, Barry and Atlanta, about people that despite their best efforts, there are complications and people living with complications and diabetes. And people will often come and say, why should I bother doing anything about this? I already have the complications.
Mhm.
How do we overcome this doom and gloom idea? Barry or Atlanta, do you have ideas about that?
Maybe I'll start. I mean, the first thing about I've been doing this 20 years, seeing people who have diabetes, type 1 and type 2. And I think the first thing I do when someone has complications is that we have to help them mourn the situation, that there's a mourning that goes on. There's been a loss, and the loss has been of a sense of, I'm going to be okay. Now, it doesn't mean something awful is going to happen. I'll talk about that in a moment. But the first thing is acknowledging the loss. So, for example, a good friend of mine, actually, who we talk about type 1 all the time, he developed when he was 25, non-proliferative retinopathy. And we talked about it back then. I was just finishing medical school. I wasn't a psychiatrist, but we talked about it back then, and he was terrified. Like he went all the way down to the worst possibility. I'll cut to the chase. He's fine. His eyes are fine. He did have laser treatment, and he's had no problem since. And we've talked about it a lot, David and I. And one of the critical things he said was he decided that he was going to take better care of himself as a result of having complications. Because he hadn't, because we'd spent high school together, and I can tell you, I can vouch for him on that. And that was the moment that he said that changed the course of his self-care. It was a wake-up call, as he said it. And he said that was the moment he started to have unbelievable care. And in fact, at some points, he's had A1Cs that are better than many of his friends that don't have type 1 diabetes. And he's really been remarkable in this way. And I guess I would say that, a complication can be a wake-up call, and many complications, in taking David as an example, and I'll ask Alana about it, with really good care, and that includes engaging with a really good ophthalmologist, because that's what he did. He got really good care and then took really good care of himself. And that was the heart of his reaction. But I want to go back to those steps. The first one is to actually recognize I've had a loss. Something's happened to me. And it's also a moment of recognizing we're vulnerable. And it's a chance to actually use something called self-compassion, that you actually pause and think to yourself that we all are vulnerable, and to take a breath and really catch that, and then ask yourself, how do I want to be remembered? Meaning with my own life, and that I want to take charge of this and really lead a healthy life from here. So when things happen that we can't change the situation, all we can do is change our attitude towards it. It's one of those moments when you're told you have complications. I guess I'd like to ask Alana what her thoughts are about the actual, how you help people cope with being told, of developing a complication.
Yeah, I echo some of your thoughts, actually all of your thoughts. And I've seen that with many people as well, about this becoming, a wake-up call and a positive driver for change in terms of managing diabetes from that point forward. I think it's important to remember that with many diabetes complications, especially the earlier ones we may see, like mild retinopathy or mild neuropathy symptoms, if you have some numbness or tingling in the feet, for example. Often those conditions will not progress if you do have good diabetes control, good blood sugar control. Some of those conditions can actually revert back to normal. One common example would be, we do this urine test typically every year that hopefully those of you with diabetes are accustomed to doing, and that's looking for any potential complications related to the kidney. And that number in the urine that we're looking at, it can fluctuate quite a bit. So you may see it go up at one time and be abnormal, and then the next time it could go back down to being normal. And so it's not all hopeless when there is an abnormality or you've developed a complication. I also remind people that the most, like Barry has said, you can't change what has already happened. So all you can do is change about how you're going to respond to that and move forward. And with almost all of the complications, the best way to move forward is to try to optimize your blood sugars or your blood pressure, your medications. So really to optimize your care as much as possible, and to focus on that, on trying to prevent any future complications or progression. So I think, that's generally how I would approach that in my practice. And it's important to remember, for example, some of the complications with diabetes, we talk about cardiovascular disease, so heart disease. Even in someone without diabetes, there is risks of cardiovascular disease. And so it's important to remember that there are health, everyone experiences potential health issues, and so we do our best in managing diabetes to try to prevent the diabetes complications, but things do come up, and we have to move forward and try to optimize as much as we can from that point on.
Thank you. That was great. People have accused me of being a Pollyanna at times when I say a person's been diagnosed with diabetes, and I say, this is an opportunity now to take care of yourself. But what I'm hearing Barry and Alana say is that when a complication happens, that's somewhat people stop and start to pay attention. And so in some ways, it's not a good thing, but it's a good thing to draw their attention to. And I've heard you loud and clear, and both of you answered, taking a look at what we've been talking about tonight. Is it knowledge that I need to help me sort of cope with this? And then, yes, it is. I was saying, some of these complications are not totally reversible, but certainly they could get worse, but we can prevent them from getting worse. And the other thing that Barry's been talking about is it's your attitude towards it that's going to be important. It's your negative self-talk. Look at another way to say, okay, this is an opportunity, I can make matters better, or I can make them worse. Let's look at the positive side of this aspect. So
And so, Gail, what I would add there is I also say, I think it's important, I'm going to stress it again, that you go through a grieving period, not for months, but just pausing and really feeling the sadness about it. And then asking yourself, I like to ask people all the time, I want you to imagine that it's 10 years from now. And looking back on today, how does that person 10 years from now advise you to be that older, wiser self about this complication? And inevitably people will say something like, I just need to take charge of my life, because we imagine, and it's true, our 10 years from now, we're going to be wiser. And that self's going to say, just take charge of it. And I ask people to think about that right now if there's someone who's struggling with complications.
thank you, Barry. Thank you very much for that. And please remember that as Alana has said, and Barry, that the healthcare team is here to help you. Okay. I know going to visit the doctors, we all share that, the sort of an anxiety. But how can you actually decrease your anxiety when you're going to your healthcare visit? I've got a couple suggestions for you. Okay. First of all, be prepared. So have identified, as we talked about this evening, you use the PAID scale, identify where your personal stress is. And then, as Alana was saying very clearly, what small thing can you do to make that better? Think about your goal, be realistic about it. And when you go to your healthcare person, have this organized in your brain, or maybe written down. Focus the conversation, be specific as to what it is that's causing you the distress, and what is it that you think you could actually work with. And is it the knowledge part? And talk about your negative self-talk going into a positive aspect of it. Always set those small steps, as Alana suggested, and be open and honest in your communication with your healthcare team. I always say, be bold, be honest, okay? And before you leave, please ask yourself the questions. Before you leave your visit, have my questions been answered? Do I have an action plan that will really, I think I can work with? And do I feel supported? Because your healthcare team is there to help you do all of those things. And if that hasn't happened, as Alana was saying, from that viewpoint, from the actual team viewpoint as well, we need to know that you are supported by the team. Sometimes it doesn't come across that way, but we need this communication to actually put it there. So the final slide that we have this evening is Barry's famous comments, is keep your eye on the prize and not the pain. Now, Barry, can you address that one?
Sure. So the prize is to have a fulfilling, happy, meaningful life. And that ultimately, every action you do to take care of yourself is for that. So no one wants to take care of their diabetes. That's a given. But they're willing to because of the prize of something that matters to them, whether it's their family, and if they don't like their family, maybe their dog, or something that in their life gives them something meaningful to look forward to. And there's definitely pain along the way of living with diabetes. But as you pointed out, or Alana did, there's pain in life. People do get heart disease without having diabetes. And we do face these stresses in life, but ultimately we keep going because of that prize of having that fulfilling life.
Perfect. Thank you, Barry, for that. So that brings us to the end of our actual questions at this point in time, but we are going to go back into the questions that you may have asked during the program. Thank you for being with us this evening. Now, following our question and answer period, there will be an evaluation sent out to you. So please complete that and send it back in so that we have an idea how we can help you better deal with your diabetes. So let's go to some of the questions that the participants have put up. Let's see. Okay, I've been a diabetic since 2003. The most frustrating part for me was, and still is, information. Where can I find the best information to help me cope with my diabetes? Who can answer that one? Any suggestions for?
Yeah, I mean, I think so. I think the question referenced that the information might be different for different countries. And that's true. There, a lot of it is common, I would say, between the major countries that make diabetes recommendations, but there might be some differences. I think, you can go to the Diabetes Care Community website for information. There's also on the Diabetes Canada website a lot of information specifically for patients. And so those would be sort of valued sources of information I would go to. If you have specific questions, then ask your healthcare team, whether it's your endocrinologist, your family doctor, if you have a nurse or a dietitian involved, then I'd encourage you to ask your healthcare team for specifics.
Okay, thank you. Here's a really interesting one. How do you stop seeing food as the enemy and enjoy meals again once you've been diagnosed with diabetes?
Well, maybe I'll start and then Alana can talk maybe a little more of the concrete aspect. So the first thing is food is the enemy. That's about as you're transitioning and seeing the impact of food on your blood sugars. And as people always find out that even if you don't have diabetes, your blood sugars do go up with food, regardless of, of your situation. So I always stress to people that that's a thought, food's an enemy. And I always say, why don't you find the foods you enjoy that also fit into the plan that your dietitian or your healthcare provider has recommended, and just begin to see it, the things you can have, the things you do enjoy, and not be so focused on avoiding foods completely, because that just leads you to want more of them.
Okay. Another question here about food, which is that, oh, sorry,
Alana
Alana.
I was gonna add two thoughts to that.
Sorry.
I had two comments. One was that I think you can, depending on how often you're monitoring your blood sugars, because the recommendations for that differ depending on the specifics of your diabetes, but you can use that as an educational moment as well. So, if you are eating a food that you think might be an enemy, you can check your blood sugar before and after you've eaten that food, and use that as an educational tool, and that might change how you deal with that situation in the future. My second thought is that, nobody's looking for perfection. I think we've spoken about this a few times tonight about not needing to be perfect. And so, sometimes I might hear, I was at a birthday party, or it was my birthday and I had a piece of cake and my numbers went crazy. One time, or, the rare occurrence where you really want to eat something and, it's going to make your numbers high. That's okay. We're human, we're not perfect. And so I think accepting that, once in a while, of course, not all the time, every day, regularly, but once in a while, when you really want to eat something that you don't eat regularly, and, it might have a negative impact on your blood sugar for a few hours, that's okay.
That brings us to a comment that some of the people have said, we talked about with the family support that they won't recognize that they have diabetes. There's the other side of that where we have the diabetes police and the family's on top of you every time you eat something. How do we deal with that aspect? We talked about people caring so much that they're on top of you. How do we handle that part, the diabetes police?
I guess, are we looking over here that I'm supposed to say something? Okay. Well, I think the first thing is it's an opportunity to be assertive, and using Gail's idea that I'm going to have her repeat in a second about the I statements, that, that I experience what, Gail? How would you say that? And then I'll come back to it. How would you set a clear boundary with somebody if they're
I feel that you're judgmental every time I go to eat a piece of cake, or I feel you're judgmental when you told me not to eat that because I have diabetes, or I shouldn't be eating that. That's
right.
The biggest comment. Yeah.
Right.
That
I shouldn't be. And you can now quote Alana saying you can have it
Yes.
At your birthday and other times that might be special occasions. And really, it's not helpful. I think it's also important to tell people it's not actually quite helpful, because it makes people want to, first of all, rebel because no one likes to be controlled. And secondly, it leads people to feel distant, to feel more distant from family members. And ultimately, the family's got to be your support team. They're not qualified to be your medical team. And their job is to support you, encourage you. And if they do have a concern, maybe mention it to you in a quiet fashion that maybe you might want to speak to your healthcare team about this. But once is plenty for people to remember.
I remember, looking back what we were talking about tonight about the knowledge part, is I remember having couples there and one couple saying to the other person, you can't eat that. And, it was a lot of knowledge information that the people just didn't have the correct information. So it's not only, and I do think sometimes the diabetes police are coming from maybe a good place, but it's being misplaced, it's a scenario. So knowledge and the talk, yeah.
So, and there was a study recently that showed that continuous glucose monitoring was very helpful for family members and their distress, because if they actually could see how you were doing, as long as it was okay, they felt better and there was less marital distress in couples, actually.
Exactly. Oh, great. Okay. So that's another use for continuous monitoring. Thank you for that one. So here's a question. As a woman in her mid-50s, is there a connection between emotions, hormones, and how it affects diabetes management? I'm going to go with you, Lana. Can you have help with that one at all?
Yeah. So, there's these nice photos or infographics you can look up, the factors that affect blood sugars and diabetes. And, there's many factors that affect blood sugar control. So stress absolutely can affect blood sugars. There are stress hormones that, can go up when you're under physical or psychological stress. Those stress hormones generally cause blood sugars to go up as well. In your 50s, if you've gone through menopause already, or you're in the perimenopause period, there may be a shift in that perimenopause going from, premenopausal to postmenopausal. There's definitely a shift in your hormones, and that can absolutely affect your blood sugars as well. I would say the good news on that side is once you've gone through menopause, the hormones for women are quite stable at that point. And so we shouldn't really see ongoing hormonal changes that would affect blood sugars. But certainly stress is one of the many factors that can affect blood sugars. And I would say that's both a direct effect through those stress hormones I mentioned, but also through indirect effects. Like if you're stressed, again, it may change how you're eating, it may change how you're monitoring diabetes, it may change your physical activity patterns. And so all of that can affect your blood sugars.
Okay, so there's definitely a connection there. Yes.
Mm-hmm.
Okay, this is a surprise, and I'm going the opposite way now. So here's a comment from one of our attendees tonight. I've had type 2 diabetes for 25 years. My A1C has varied up to and over 9, but always around 7. I eat things in moderation. My doctor doesn't seem overly concerned about my readings, and I'm not, and I feel no stress at having diabetes. Your program makes me feel that I should be stressful. Do people that have stress with diabetes, are they stressful about most things? So we certainly didn't intend that one. Barry, I'm going to put that one right to you.
Okay, so I think that's great that someone's not stressed by it and just is taking care of it and is living their life with diabetes. I guess we didn't think they'd come on to this telecast here. So that was one thought I had. The other one is that, everybody's, can have moments of that stress over time, but stress is helpful only if it helps you. So a little bit of stress motivates people to, let's say, test their blood sugars, take care of themselves, but only to the point that it's increasing your ability to be focused and attentive to your care. Once it passes that level, it becomes a problem. So the person that asked the question obviously has just the right amount of stress, because stress is good. We need stress, right? If you want no stress, you're having a dead person's goal. We all have stress in our life, and we want to have an acceptance of that. And I bet that person, if we ask them, they do have some healthy stress that gets them to take good care of themselves.
Okay, because we did not
I
mean to
might,
create stress, right?
I might add to someone in that situation, the next time you're seeing your doctor about your diabetes, maybe ask some questions just to make sure, are my blood sugars where they're supposed to be, or where do you think my blood sugars should be? And just make sure, like if your doctor is telling you everything's going great, everything is where it needs to be, then that's great. Perhaps you don't have much reason to be stressed, but make sure that you're informed, that you're asking questions, and that you're, that you're doing well.
Perfect. Yeah, we don't want to create stress, but if it's there, we'll deal with it. So here's somebody asking, does everyone have a healthcare team? I only have a physician. Well, what do we do?
Yeah, I think that can vary. That can certainly vary. So for someone who has pre-diabetes or type 2 diabetes, that's perhaps not on insulin, it might, you might see your family doctor for diabetes. You may not have anybody else involved. There is diabetes education that is routinely recommended for everyone when they're diagnosed with diabetes or even with pre-diabetes. So hopefully you have received diabetes education at some point. That's usually delivered by a diabetes educator that includes nurses, dietitians, or pharmacists. There may not be an ongoing, relationship with those people. And so you may just see your family doctor. If you're seeing an endocrinologist often and not always, that's when there starts to be a team in terms of, other support from nurses, dietitians, or pharmacists, sometimes social workers as well. So it really depends on the specifics of your diabetes. And also to some extent, I'm sure where you live, the resources and who the team members are might differ based on where you're living as well.
Great, thank you. Here's one from a family member. It sounds like, how do you get someone to realize that there'll be complications if they keep their blood sugars so high? They say they feel normal now, but I know that their blood sugars are high. So this is sort of a family member now that's trying to work with the other person, with the person that's not recognizing. What would we do about that? Or, well, any
I don't know if Barry has thoughts. I think my natural response would be to try to explore with the person with diabetes, what's driving their thought process. So what is driving them to, not monitor their blood sugars or not control their blood sugars, and not worry about, the risk of complications. So I would worry that, perhaps there is distress that's driving that behavior that we need to address. Perhaps there could be depression driving that behavior, that sense of doom and gloom that we spoke about. So I think for me, I would be exploring what's the motivator for that. And then I might get Barry involved to help.
So how would you carry it from there, Barry?
Well, I think, so I would carry it from there, following what Alana said, that I would test to see if they're depressed. But then, and what we've been talking about, remember, the number one response to distress is avoidance, is just backing away from the problem. So there's something underlying it. The underlying it sometimes we see is not actually a psychiatric condition, just that they feel that if they actually take care of their diabetes, it's going to take over their life, which is a thought. Like, that it's going to completely overwhelm me and take over my life if I take good care of it. And I do sometimes find versions of that. And I help people begin to take some of the things that Alana said earlier, small steps, encourage them to go back to their educator, to their endocrinologist, to set those small steps. And often, we're very lucky in our team, Alana, that we have, lots of resources, and we meet as a team and try to discuss how to best approach it using coping strategies for their emotions, my department, and having actual interventions that are going to help that person in a safe, not overwhelming way take control of their care. I think the question also asks, how do you deal with family members that aren't taking care of themselves? And I think you're supportive. Like, you're not supporting them to not do anything, but you're maybe cheerleading them on when you, a little bit on when you see them take care of themselves. That's great. Not much. I want to stress that. Family members, it's kind of like when I give mental health advice to my family members. Never goes well despite my degrees.
Oh,
Alana, any
very.
thoughts on that? I'm not on my family members, but on the idea of like, how do you cope with someone when a family member is the one who's saying, hey, my relative, you know, they kind of tell or out their family member.
Mhm. Hmm.
Does that happen to you?
I've seen it again. I've seen it more in the relationship of the diabetes police when you're out eating and someone says, you know, all of a sudden they'll say they're trying to protect you and they'll say, but you've diabetes, you shouldn't be eating that. And so the whole
Right.
population now knows I have diabetes. Well, thank you. You know, this sort of the feeling. Again, I think some of it boils back down to the knowledge and how you're going to support me. I can eat this. And someone did ask a question here, and I think we've answered it, but I just want to sort of, maybe we're coming toward the end of our time, but I just want to put this, is it okay to eat something not recommended once in a while? And this is where the perfection idea comes in. And I think people have to have more knowledge that what diabetes is and that we can eat these things occasionally. We have systems where we can monitor our blood sugars, we can know. So we need knowledge and have that, share the knowledge of how to deal with diabetes. And then the other aspect is not to get discouraged and to think more positively that they're really just trying to help me, this family member, in some ways. But I feel, and go with the I again, okay? I feel that, you know, I feel upset or I feel embarrassed when you've said this. Can we chat about it? And there's another way of going about doing this. So, yeah. Well, I think unfortunately we've come to the end of our time. Are there any last words, Barry or Alana, that you would like to share with us to sort of put a cap on what we've talked about tonight? Or
I guess really for me, it's back to feedback, not failure, making sure that people actually are recognizing that it's stressful to live with diabetes and that it's our attitude that's going to matter, catching those thoughts and beginning to recognize opportunities to reach out to others to get their support. So sometimes it's really important to go from that place of feeling lonely and asking for support, which is a vulnerable thing to do, but in the end can be very helpful.
thank you. And Alana,
I think I think the highlight of what I spoke about is the incremental steps. And so, trying to make small steps forward, not making a goal that's too big, that's not going to be achievable. I've scrolled through some of the questions as well, and I see there are quite a few questions about, the team, the physician, whether you're seeing an endocrinologist or not. So I would encourage you to ask your doctor, if you have questions about whether there's value to seeing someone else in addition to the doctor. And at least in Ontario where I practice, but I think across Canada, the government funds diabetes education. And so you could always look into diabetes education centers in your region. A lot of them are doing virtual diabetes education now since the pandemic. And so if you're looking for more information, that would be a great place to start as well.
I also saw in the questions, as you're saying, a lot of questions about facts about diabetes and about the complications. And I strongly encourage you to ask your physician to refer you to a diabetes education program, because that's where you can get a lot of the answers to those particular situations and facts about diabetes. I'd like to summarize what I heard tonight with I love the idea of catch your thoughts, and that we don't have to be perfect. Okay, we are not perfect. Our whole being is not perfect, and we'll actually work on our diabetes small steps at a time. But catch your thoughts. It's not the situation, it's your thoughts that are actually the important part. And I love Barry saying you can't control your thoughts. Well, but we can control how we react to them, I think, is the issue that we've been chatting about. Well, I would like to thank you so very much, the audience, for being with us this evening and for the great questions you've put out there. And please, when the evaluation comes your way, if you could actually fill the evaluation in and let us know what you thought and let us know what you're interested in hearing from the experts. So thank you, everyone, for this evening, and have a great evening.
Bye, everybody.
Take care.
Take care.